Start.
Yes, ma'am. Yeah. 3, 2, 1, go.
Yes, sir.
Thank you, Sakiti. We welcome all of you to this AI Academic Wing of Assisted Reproduction, Trichy, Tanjavur, Tiruvarur Societies webinar for the month of actually September, but we are doing it in October. And we are very happy to have an esteemed speaker who's a great researcher herself, Dr. Priya Bave. And I would request Dr. Manjula to introduce the speaker. The thing is, Priya was asking about what the society is actually. It is the academic wing of assisted reproduction. T is for Trichy, Tanjavur, and Tiruvarur. These are all three districts south of Chennai. It's a south of Tamil Nadu. And we have got good number of reproductive medicine specialists here, but we do not have anybody to represent ourselves at the local authority level. And that's why this was formed after the new ART bill came, so that there is some clarity for the young practitioner who is starting practice in a rural area where she may not have any access to information and knowledge. And we have made it very authentic because we do not have ask anybody to pay any fees. We do not want to collect any money for this society. And we do only webinars. It's all only virtual programs. We do not have any physical programs. We do not want to waste our time and resources on traveling and spending time in other work, which may not be very useful for our clinical practice. And that's why we have it only virtually. And we've got great speakers who have come to this society and given great talks over the years. And we have only people who are doing work originally, and they present their work at this forum so that we get to learn from them. And we do not want to have review talks from outside the country, which may not be of much of use to a practitioners who's practicing separately alone in a single center. So that is actually the basis of how the society was formed. We started as 30 members, and now we have grown to 65, and we hope to grow more. And now we register our society with the registrar every year. We renew it also. We have got properly maintained accounts, and we've got a good treasurer, Dr. Manjula, who does that for us. And we also have monthly programs, and our EC meetings are always done on time, so that we are accountable to the registrar of societies. And now we have registered the society with the Tamil Nadu Medical Council, so that people who join the program can also avail of the credit hours for their academic this thing, because Tamil Nadu Medical Council mandates that everybody should have at least 30 hours of learning every year. So probably they can use this for their furthering of their career also. And we actually conduct these programs so that we interact with the speakers also, because most of the times nowadays it's just a rushed program. 10 to 15 minutes is given to each speaker, and nobody gets to interact with them. And that's why we stick on to one speaker, and you would like to interact with him or her so that we gain knowledge from them. And we're extremely happy to have you with us, Dr. Priya, because we know that you do such great work, and you're also very original in all your thoughts as well as work, and like to gain from that. Now, may I request Dr. Manjula Appature, the treasurer of the society, to formally introduce the speaker.
Thank you, sir. Thank you so much for giving Dr. Priya Bave the insights about our AART society. We welcome you, Madam Dr. Priya Bave Chitawa. She is the consultant and head Department of Reproductive Medicine, Bansal Hospital, Bhopal, FNB Reproductive Medicine teacher, ex-faculty DM Reproductive Medicine, Foxy recognized trainer in basic and advanced infertility management courses, Cochrane reviewer and author. She's then secretary MP chapter IFS, awarded the Dr. Pankaj Talwar Gold Medal at IFS 2022, Ironman triathlete, MC member IAGA 2023 to 2026. Dr. Priya Bave is going to speak about chronic endometritis, which is a hot burning topic. And over to you, madam.
Thank you so much, Manjula madam. Thank you for this very kind introduction. As I begin, I would like to really extend my thanks to Dr. Charmila. I have been admiring your work since your tenure in the Clinical Research Committee of Foxy. And each program that Dr. Charmila does will have something different. It will be always academic. It will always involve the best of people. And it will be always timely and wonderfully executed. So thank you so much. It is a pleasure to be part of your organization always.
Okay.
This society, I am just fascinated by it because out of 63 members, almost 40 plus are already online. And the first time I have joined a webinar 15 minutes prior and many members were already there. Plus, it is in the presence of J.M. Kannan, madam. I didn't know that she even knows about me. I have been admiring you from a distance for decades now. So I hope I am able to do justice to my talk. So this chronic endometritis topic is actually very close to my heart because
Priya, you can switch off your
the
video. Probably
veggie.
then the network will be better. You can switch off your video and then talk alone. Priya,
Okay.
because I
Better
think
now? Is it better now, Sharmila?
better now. Your voice is better. Otherwise, it cracks.
So, who have studied IT, we always were taught that cervical mucus is like the Colossus of Rhodes. Colossus of Rhodes is a mythical figure. It was supposed to be a very big statue that guarded a big port. So we all know that cervical mucus is Rhodes which uterine cavity the
I think her connection went off. Let's wait.
Is it raining there?
I don't know, madam. She started screening again.
Okay.
audible now.
Yeah, audible now. Yes,
I'm
yes,
so
yes.
sorry for the interruption. I don't know why it
That's okay.
happened.
That's okay. It's part of the game.
Yeah. So eventually what happened is that as time went by, we realized that cervical mucus plug is not the Colossus of Rhodes. It is an inhibition, but it does not block the passage of ascending bacteria from the vagina, not only during pregnancy, but during non-pregnant state also. So alongside what was also happening is that we were gaining understanding about something called as the uterine microbiome. We always thought that microbiome is there in the gut, it is there in the oral cavity, it is there in the vagina for sure, but uterus was always considered sterile. But what happened over the last 10 to 15 years is we understood that uterine cavity is also populated by all these organisms. And just like there can be a dysbiosis in the vagina, there can be a dysbiosis in the gut. There is also an entity called as dysbiosis in the uterus, wherein the normal proportion of these organisms is altered. Now, the problem is that microbiota research is in the infancy. So while vaginal microbiota has been properly mapped, gut microbiome also has been mapped, but uterine microbiome, still we are learning what are the normal proportion of the bacteria that are there in the uterine microbiome and how alterations of this can contribute to various reproductive issues. So this is a very wonderful article. Back in 2008, I started learning more about this, and this was an article which I found very fascinating. Uterine microbiota, are they residents? Do they live in the uterus? Are they tourists? So, when you do a procedure like DNC or an HSG, are you introducing certain microbiota which are going to stay in the uterus for small time? Or are they actual invaders and the presence of these is always pathological? So this is something which is still a question to us. And the ways in which microbiota can enter the uterus is, of course, either through the uterus, either through the fallopian tubes, or through the vagina. Now, the microbiota is related to all these factors: age, hormones, ethnicity, genetics, sexual habits, genital diseases, and even the menstrual cycle date. And what these changes do is that they lead to a lot of changes in the environment of the uterus. And the entity which I really want to talk about today is not just the dysbiosis, but actual inflammation of the endometrium. Endometritis is considered as an inflammation of the endometrium, which is associated due to microbial colonization in the non-pregnant state. And the characteristic or the pathognomonic feature of chronic endometritis is the presence of plasma cells. In fact, even a single plasma cell is enough to diagnose it as a chronic endometritis. Now, the most common presenting symptom of endometritis it can be totally asymptomatic. I'll be presenting some of my own cases where there were no symptoms. It can be abnormal uterine bleeding, pelvic pain, and we will be seeing cases of this as we go on. The commonest pathogen which we face in central India is Mycobacterium tuberculosis. When I was training in CMC Vellore in my fellowship days, I had never seen a single case of genital tuberculosis. But once I came back to MP and started practicing in Bhopal and Indore, not even a single day goes by where I don't see a patient with genital tuberculosis. But over the last few years, I have realized that there is a host of other bacteria which we can now diagnose with the new test, that is DICE, and they are all of these. Now, the big change which has happened in the endometritis research is the arrival of molecular test for diagnosing of infection. For us, the gold standard for infection has always been culture. But when the bacteria are in very small number, the culture cannot pick it up. That's why whenever you take an endometrial sample and send it for culture, it will come out sterile, even if there is a pathogenic or a potential pathogenic bacteria. But now we have RT-PCR. We also have now next generation sequencing. So with NGS, the specific identification of chronic endometritis is almost in 91% of the cases. Now these tests are easily available to all of us. And I'll tell you what are the tests that we use. So now what happens is, once you get a test that diagnose, you will get a lot of literature. So if you see the timeline of uterine microbiota, the moment sequencing came in, the moment next generation sequencing came in, there was a big explosion in the number of articles and in the number of studies that we could see on endometritis. Now the test or the study that we did, now we were always fascinated with
Slides are not moving, Priya. Is it okay?
Yeah, for me it's moving.
It's only at chronic endometritis still.
Don't tell me.
The symptoms, only at the symptom level.
Okay, let me just
First
share
slide,
my
madam.
screen again. No, but I've gone through many more slides.
But we are hearing you, but the slides are not moving for us.
Are we at common pathogens?
No, most common presenting symptoms, you are there. Abnormal uterine bleeding, pelvic pain, RPL,
Okay.
subfertility, dyspareunia.
I'll just start sharing again.
Okay.
I'm so sorry for this. I don't know why the network is so bad today. Is it better now? Are you able to see?
Yeah, I can see that.
Yes, now we are
Ecological
able to
condition.
Yeah. Yeah. So I think this was seen.
It was seen. It was
okay.
seen. This was seen.
Okay. So I think we stuck here.
Yeah, stuck here.
Okay, perfect. So these are the common pathogens. So this is the explosion of tests, the explosion of the studies that we started having after the availability of next generation sequencing. And this is the article that got us on the way of testing with the MUM1 testing. So what happens is, we all understand that the pathognomonic for chronic endometritis is MUM1. MUM1 is an immunohistochemistry marker which goes and marks the plasma cells. So far for plasma cells, we had CD138. There are many centers in India which do CD138 testing. But CD138 also is expressed in endometrial epithelial cells. So the sensitivity and specificity is 85 and 79. But MUM1 has a higher sensitivity and specificity. And because presence of even few plasma cells is pathognomonic of chronic endometritis, so even if we find 4 to 5 cells which are MUM1 positive, we will think that this patient has chronic endometritis. We did a study on chronic endometritis. So this is the retrospective cohort data of our patients. We started in May 2019. This was a time when MUM1 testing was not available anywhere and we had to import the kit. We submitted all our patients who are undergoing a laparoscopy to MUM1 testing, even if everything was normal. Around the same time, the Delphi consensus on the diagnostic criteria for chronic endometritis was published. And they said that presence of 3 characteristics, micropolyps, focal hyperemia, and stromal edema, is an indicator of chronic endometritis. So what we did is we did a MUM1 testing, and we also compared it with the presence of micropolyps and focal hyperemia. Stromal edema, we did not, because stromal edema is a normal feature of patients who are undergoing the test in the secretory phase. In my unit, we don't always schedule the laparoscopies in the proliferative state. Many of them are done in the secretory phase simply because we want enough tissue to send for the sampling. So we send for MUM1, gene expert, culture, smear, and biopsy. So we send for 5 tests. That's why we need enough sample. That's why we don't schedule immediate postmenstrual. So some of these patients actually go in the secretory phase. So this is the 2x2 table. So what this means is if we saw focal hyperemia on hysteroscopy, the number of patients who had a MUM1 positive on biopsy was, and IHC was 29. The patients who had MUM1 positive, almost 245 of them did not have focal hyperemia. That means a plasma cell can be present without the hysteroscopy showing focal hyperemia always. Now, if we were to take out the sensitivity of focal hyperemia for chronic, so we have taken MUM1 as the gold standard. The sensitivity of focal hyperemia is only 10% because it is present in only 10% of the patients who have immunohistochemistry confirmed endometritis. The specificity is very good. So that means if the patient does not have MUM1 cells, it's very unlikely that she will have focal hyperemia. Okay. So don't just go by focal hyperemia. Please send MUM1 because many patients will not have focal hyperemia but will have chronic endometritis. But if chronic endometritis is present on IHC, most of them will have focal hyperemia. There will be very little who don't have it. Now, similarly, for the presence of micropolyps, all of us are now aware that micropolyps are a sign of chronic endometritis. It was reported for the first time by Ettore Ciccinelli way back in 2011. And now all of us are aware. So the sensitivity of, again, micropolyps is 13%. Specificity is almost 100%. And if you see the positive predictive value, it is very good for both of these. But negative predictive value is not that great. So what this means to say is, in hysteroscopy, always be aware of presence of micropolyps and focal hyperemia. I'll show you the videos in the cases subsequently. But please always also start testing for MUM1 because many of these patients do not have any features on hysteroscopy, but they are MUM1 positive. Now we know that how to find out the inflammation, that is the presence of plasma cells. But what about the organism which has caused this inflammation? So here is the role of the DICE panel. Now, DICE panel is a test which has been floated by one of the companies, and the chief scientist is Dr. Murugan Nandagopal, who has a lot of work in this field, and they use RT-PCR. They don't use NGS, they use RT-PCR. Currently, we are also evaluating another lab which is doing a next generation sequencing for endometritis bacteria. But in our DICE study, what we have done is if the patient had MUM1 positive, or she had any other features of chronic endometritis, very florid features, we have started sending now DICE testing. So DICE testing will give us the primers for these bacteria. And if these bacteria are present, then they will also tell us the antibiotic which is to be given by the CDC. So this is a sample report. So here they have tested for Mycobacterium tuberculosis, NTM, gonorrhea, chlamydia, mycoplasma, urea plasma, and all these 4 extra. Here in this patient, the Mycoplasma hominis has come out to be detected. So then for Mycoplasma, the company will recommend us minocycline twice a day for 12 days. Now, our sample size for DICE is actually very less, so we've not been able to publish it. It is something which we are still looking at. So I'll just now share a few clinical cases. Now, this is a 42-year-old female, para-1 living one, who presented with chronic pelvic pain. We did an MRI, we did an ultrasound scan. We did not find any endometriosis. We did not find any evidence of adhesions. But the patient had really lot of pelvic pain, and the telltale sign was this fluid in the endometrial cavity. If you look at the hysteroscopy, can you see a very pale endometrium and all these micropolyps? And do you see also these red dots. These are focal hyperemic spots. So this patient is classically showing us both focal hyperemia as well as lot of micropolyps. When we did the immunohistochemistry, 1 to 2 cells were positive per high power field. So in such patients, when we did this patient, we did not send dyes, but now in all these patients, we have started sending dyes panel in order to know the exact bacteria which is causing this inflammation. This is a second patient who has come with the primary infertility. Endometrium you can see on scan looks okay. It looks like a not a very great triple line, but a okay endometrium. There's no fluid in the endometrium. But look at her hysteroscopy. So in her hysteroscopy, you see a pale endometrium, and near the right lateral wall, we are also able to make out micropolyps, and these white dots are nothing but focal hyperemic spots. So whenever we look for micropolyps, just two things to remember. One thing is that it's very important to do it in the vaginoscopic manner so that we don't raise the flaps of endometrium. Otherwise, what will happen is we'll not be able to see the micropolyps and the focal hyperemia. And look at her mum1 testing. 10 to 12 cells are positive in a single hotspot. Earlier, till 2 years ago, we were giving azithromycin or doxycycline to this patient, taking a very detailed history of genital tuberculosis in the family or personal history. But now what we have realized that all chronic endometritis is not tuberculosis. So we do send a DICE panel in these patients. If the DICE panel is positive, then we treat as per the CDC guidelines. Now this patient, it looks like a good endometrium, although the thickness was only 5 millimeter. It looks like a triple line endometrium. She came with very low flow. And when we did a hysteroscopy, you can see pale endometrium. Remember, this is well into the proliferative phase, so very thin and pale endometrium, and patches of focal hyperemia are seen here. These are the micropolyps. These red dots are the micropolyps. But in this patient, the mum1 was negative. Although these cases wherein we find hysteroscopic findings but mum1 is negative are less, but there are some of these cases like this patient. Now, the next patient is again a patient who came with primary infertility, irregular cycles. The endometrium looks non-specific. And if you see the hysteroscopy, a very classic picture of very visible endometrial vessels. This is again not post-menstrual, so you can understand that it's a very thin endometrium. And we are seeing focal hyperemic spots here. The glands are very less in number. And this patient again had 10 to 12 mum1 cells positive. Unfortunately, we did not have the DICE panel at that time, so we did not know what is the pathogen. This is a patient who had no menstrual complaint. And here again, you can appreciate these small micropolyps. Remember to do it with less pressure. If you use too much pressure in hysteroscopy, you will not be able to appreciate micropolyps. Now here again, that's a micropolyp that is there. And micropolyps are very commonly seen on the lateral wall and around the ostia. This patient also had mum1 positive. Now, had we just relied on biopsy to find plasma cells, maybe we would have missed it. So I think the burgeoning role of immunohistochemistry is now coming up. This is a patient who had septate uterus. We did the septal resection, but persistently she had fluid in the endometrium. And on hysteroscopy, non-specific findings, just a little diffuse hyperemia was present, and we found that mum1 test was positive. In this patient, the DICE panel also was positive, and we treated her with antibiotics. So, one last few considerations about genital tuberculosis. Actually, we started doing mum1 testing to detect the chronic endometritis due to genital tuberculosis, because this is the topic wherein we have maximum work. In fact, we have published the largest case series in the world on laparoscopy, hysteroscopy findings in genital tuberculosis. So before DICE, we were thinking that most of the endometritis in our patients is because of tuberculosis. Now, this is one patient. She was reported as a chocolate cyst outside, and she came to us for endometriosis excision surgery. This is the left adnexa, but just see that we are not able to see any ovarian tissue around this mass. So I knew that this was probably caseation. Although my resident said that it looks typically like a chocolate cyst, look at what we found on hysteroscopy. Caseations right from the cervical canal itself. If you see the hysteroscopy, very telltale features. Look at these hyperemic spots. Look at this very, very unhealthy endometrium, pale endometrium around the ostia, and total loss of vascularity of the endometrium. Endometrium looks absolutely white. And if you see the laparoscopy picture, it is a shocking picture. Look at this, completely destroyed tubes, huge hydrosalpinx with a big caseous mass right there, and dense perihepatic adhesions. So this is our paper on the utility of MUM1 to detect chronic endometritis due to genital tuberculosis. We had published it last year, but what we did is all the patients who were MUM1 positive, we looked back at their laparoscopy, hysteroscopy findings, and if we found features of genital tuberculosis, so MUM1 IHC positive was present in genital tuberculosis in 28 patients. But 32 patients who had genital tuberculosis had negative MUM1. This is because tuberculosis will not always affect the endometrium. Sometimes it may just be an endosalpingitis. Sometimes in non-genital tuberculosis cases, MUM1 was positive, and this was really bothering me. I wanted to know what leads to chronic endometritis in patients who have plasma cells but who are not genital tuberculosis. And that is what led us to the next step, that is looking at the DICE panel. We are collating our data and very soon we'll be publishing our data on DICE panel. So if you see the comparison between histopathology, gene expert and MUM1, this data, I really feel it is incomplete now because we have only looked at gene expert. We should also have DICE panel because all endometritis is not genital tuberculosis. Now, last, something which bothers all of us IVF specialists, that is fluid in the endometrial cavity. I don't know how common it is down south, but in our unit, every third day, there is a patient with fluid in the endometrial cavity, and we are really bothered. We looked at the data, but there is very little data. And the quality of the studies, I am not happy. So we have now started collating all our cases with endometrial fluid. This is one patient which we have encountered yesterday, a 34-year-old female married for 24 years and primary amenorrhea. Don't get surprised, women do get married at the age of 10 in MP still. So this is the scan. You see a very non-specific thin endometrium. And we told her that your chance of resumption of menses is very less. We went in and did a hysteroscopic adhesiolysis, started ATT for her, and she has taken ATT for 9 months. Yesterday, when she came for scan, this was the scan findings. We gave her estrogen. There is no very poor endometrium on estrogen. And look at this endometrium on hysteroscopy. Right from the area of cervical canal, we are able to see the adhesions. Once we negotiate and go inside, you will be able to see very classical shape of the uterus, that is like a Y-shaped uterus. Y-shaped uterus because the adhesions, they form on the lateral wall and they form on the fundus. It sometimes look like a septate uterus, but it's actually the adhesions. That is because the uterus is getting continuously bombarded from the uterine arteries by the bacteria, and you see the central band of adhesions. This is because the bacteria are also coming from the ovarian artery. It is a hematogenous spread. So look at this. You can see endometritis features, that is small micropolyps, focal areas of hyperemia, very pale endometrium. Now in this patient, we did an adhesiolysis. We were happy. We gave her 9 months ATT, but still her endometrium is very, very non-specific and we have not been able to do a transfer for her. This patient still is, so this is the initial hysteroscopy. You can see all these adhesions. And this is the PRP injection that we did, but to no avail. So to conclude, chronic endometritis is something that we are just beginning to understand. The time has come where all of us start collating our data of patients with endometrial fluid, patients with micropolyps, patients with focal hyperemia, start sending MUM1 testing, start doing DICE panel in these patients, and then put all our data together and try to make sense out of it. I will admit that in the last 3 years, I have learned a lot and I'm still on the path. I feel that we know only 10%. When we put everything together, only then the clear picture will emerge. Molecular tests are quite expensive, but I think the type of insights that we have got by spending 2,000, 3,000 on Mum1, I think it has helped us treat our patients better. I think we were missing a lot of patients and we were also over treating or incorrectly treating, because see, minocycline and all we were never giving. We were only giving doxycycline. But many of our patients in DICE panel are coming for mycoplasma positive. So hysteroscopy, I think, is a very good tool, but don't do only hysteroscopy. Please send for all the tests, biopsy, Mum1, gene experts, especially if it is tuberculosis endemic, and also the new test which is coming up with NGS. I think we should all start trying in our patients. So thank you so much for a very patient hearing. I'm sorry for the initial network issues, and I'll be very happy to get your inputs, your experiences about this condition.
Thank you. Yeah. Thank you so much, Priya. Very, very, very clear as well as like very thought-provoking, because as you said, it's not very rare in South also. We get lots of patients with endometrial fluid where we are like, we don't even understand what we are going to do with repeated treatments again and again. But I'll just go to the questions. There's a question in the chat box. Dr. Reena Prabha Gokila has asked, how was the vascularity in ultrasound in those patients with a pale endometrium?
See, there are 2 or 3 problems in seeing the endometrial vascularity. One is that it has to be strictly mid-cycle. Second is that these patients need to have a good ovarian reserve and they should be ovulating. Now, you saw in our case series, we have women at 40, 42. Some of them have very low AMH. So practically there's no follicle. Secondly, what happens is that because in our unit, there's not one person who is doing the scans. There is a lot of inter-observer variability because we have residents who do the scans. So in my study, we are not able to give you very good idea about endometrial vascularity. But all the patients who had a pale endometrium, we never found a very beautiful zone 3 vascularity. That is for sure. But we are not able to publish because of the observer issues that we have being a teaching institution.
Oh, okay. And the second question from her is, how do you send the specimen for Mum1? Is it endometrium in saline?
So Mum1 is an immunohistochemistry marker. Like all IHC markers, you have to send your biopsy sample. That same biopsy mounted sample will be subjected to IHC staining. So send it in, and it compulsorily biopsy has to go. It has to go in formalin, not in normal saline.
And the Mum1 will go in saline, right?
No, Mum1 will go in formalin. So the same
Formalin
biopsy
only.
will be
Okay.
subjected to IHC.
Okay.
So what you can also do is you can save blocks, and later on you can do the Mum1 testing in that same block.
Okay. Okay. Yeah. Right. Perfect. Understood. Dr. Jayam Kannan wants to ask a question. Madam?
Yeah. Thanks, Priya. Ever since 2011, we had this big word of strawberry appearance in the endometrium.
Yes.
That was the colloquial word which was given to these findings of these micropolyps. We have been looking for it, and we have been treating with doxycycline, and of course, we have shifted to minocycline also. Now, you said luteal phase laparoscopy. Now, for the AART people, please tell them what is the ideal time for doing a laparoscopy if you do not expect an endometritis. That is question number 1. Number 2, is as you are getting every day one case of tuberculosis, do you think that you would like to do a small endometrial biopsy sampling prior to your hysteroscopy, so that if you find there's a tuberculosis positive, yes, you treat it before you do your hysteroscopy? That is number 2. Number 3, if the patient is not going for a hysteroscope, can you say that you in the luteal phase, you can get a big sample by endometrial biopsy and send them for all the mums, dyes, and other things also? Number 4, how many therapies where you inject?
Okay.
Number 5, minocycline, how many cycles? What is the interval between 2 cycles? So 5 questions.
Okay. So ma'am, I'll take the last one first. Minocycline we give for single time, but we had one patient who still had fluid, so we have repeated the minocycline for 12 days again.
Right.
But
Second
this
is
is only CDC based, so we don't know, because these PCR samples can't be cultured, so we don't know which bacteria this organism is susceptible to. PRP I inject in the anterior wall, posterior wall, lateral wall, and whatever remains, I just leave it in the uterus. Before I leave it, I just stop the inflow and leave it and come out.
How many
Third
times?
question. Yes.
Single dose
Third,
is enough? Single time is enough, PRP?
ma'am, actually, our results of PRP have not been very great.
Okay. So
Actually, when
that
we
is it.
started,
Yeah.
we got a very good result. So we are reserving it for very hopeless patients where we are not able to do anything. We are
Okay,
not.
that is everywhere the situation. The next question is MEB instead of hysteroscopic sample in the luteal.
Yes, ma'am. So actually, my very good friend, Dr. Mamta Deendayal, their unit, they do a routine biopsy for everyone. And then they start the ATT
Oh,
or any treatment. But what we have found in our data, actually, this I missed putting that British Journal paper we have published in BJOG
yeah,
that
I have
our
seen it.
patients, although we sent all 5 tests, but in most of the patients with florid tuberculosis, all the tests are negative. Now you just look at this, ma'am. Gene expert is positive in 0% of the cases.
Okay.
Histopathology in 15% of the cases. So the positive predictive value of both biopsy and gene expert is very poor.
Yeah.
So we don't want to miss. I have felt that laparoscopy for me is the gold standard. And
Okay.
over a period of long time, we have never seen a flare or never any problems. Some patients with abdominal tuberculosis develop little bit of distension after laparoscopy.
Okay.
But it
Ideal
is
time for
manageable.
laparoscopy in any infertile couple.
So here my opinion is little different from everybody else's.
That's what I
I
say.
know
Ideal time.
everybody does it post-menstrually, but over the
Yeah.
years we have noticing more and more hysteroscopic features of endometrium. Earlier, we used to, dilate the cavity, go in with big
Yes.
hysteroscope, all the flaps were raised, we would only see the ostia, presence, absence of septum come out. Now we are able to, with beautiful scopes, we have Karl Stoll's Rubina, we are able to see, so many features of endometrium. So I like to do mine in late proliferative or even luteal phase, I'm fine.
Is there any evidence saying that luteal phase is better than post-menstrual phase?
No, not yet. I have had discussion with many people who are working on endometrium internationally also. So they also don't mind doing it in the luteal phase, but I
It
have
is not
no
still clarity is not there. Anytime in except on the at the time of ovulation, anytime in the menstrual phase, except menstrual time and ovulation time, we can take up hysteroscopy. If you suspect in a case of previous curettage or repeat pregnancy loss or anything where we expect endometritis, probably luteal may be more ideal. Can I
Right.
take the AART members who are now nearly more than 70 people, 75 have joined? Isn't it? So it's a good number for you, Priya. That shows the interest that they have in your lecture. Okay, thank you. Go to others'
Thank you,
questions.
ma'am. Thank you so much. Thank you.
Dr. Smita Lakshmi has raised her hand. Would you like to ask a question? Dr. Sumita Lakshmi Balasubramanian. Please ask your
Yes, ma'am.
question. Yeah,
Yes,
please
ma'am.
ask.
Yes, ma'am.
Yeah.
Good evening, ma'am. That was an excellent lecture. Ma'am, I had 3 subsets of patients with chronic endometritis. I mean, like 3 kind of different manifestations. One had specific calcifications in the ultrasound, wherein nothing helped, the biopsy, nothing helped, and PRP had actually we are trying on PRP right now. And as you told, she had some minimal fluid in the endometrial cavity, ma'am. Is it possible to do immunohistochemistry in the endometrial fluid, ma'am? That's my first question. Or do you need an endometrial biopsy only?
So immunohistochemistry can only be done on formalin fixed samples which are sent for biopsy. So it cannot be done in the fluid. So the formalin fixed tissue is subjected to immunohistochemistry marker studies. Number 2, calcification in the uterine cavity is something called as osseous metaplasia of the endometrium. And that usually happens if the patient has a late miscarriage. It's not that the fetal bones are left there, it's the endometrium which becomes metaplastic and turns into bone. But sometimes it can actually be caseation.
Yes, ma'am.
Or there could be some calcifications which are subendometrial, which are very characteristic of tuberculosis. In fact, no other organism will cause caseation or calcification except tuberculosis.
Okay, ma'am.
I know
Okay,
it's
ma'am.
very rare down south, but you should evaluate that. And the problem with tuberculosis is the moment there is an endarteritis and fibrosis, all the bacteria become submucosal. So whatever you do, you scratch the surface, your gene expert culture, smear, everything will be negative. So please do a laparoscopy for this patient. If you find caseation, tubercles, typical features of tuberculosis on this thing, you should start ATT for her.
ATT. Yeah, ma'am. One last question, ma'am. There was another patient where the TB PCR was negative, but she had tubercles on the ultrasound. So empirically, are we justified in starting ATT for such cases? She had a bilateral tubal block. I mean, like all other features were fine. So, but TB PCR was negative. So, are we justified in starting an ATT empirically with the clinical and laparoscopic findings?
In
So
Tamil
there are
Nadu, you
two
can't. In Tamil Nadu, you can't.
So
Yes.
Okay, ma'am. Okay, ma'am. Okay, ma'am. Okay.
So two things. One is that now we have what is called as the NTEP, National Tuberculosis Eradication Program. And NTEP wisely is focusing on extrapulmonary tuberculosis. In the extrapulmonary tuberculosis guidelines, it is very, very clear that if the clinician feels that it is EPTB, whether pelvic tuberculosis or anything, you will not be questioned. You cannot be questioned. You are absolutely fine to start the ATT. In fact, government will send the medications to your clinic and help you prescribe them as far as you notify them. So in my clinic, since the last 7 years, I have all the medicines. We prescribe them free of cost. So the government has given this to the private hospitals.
But what
So-
will be the confirmatory test for in an endometrial biopsy? Because if gene expert
So-
is negative, how are you going to prove
The
it's
gene
tuberculosis?
expert in the largest series that we have published was negative in all cases.
Hmm.
This is because all the labs do not have capability to process the solid tissue that is endometrium. There are very few national reference laboratories which have the capability to process endometrial tissue. So most of the times gene expert will be negative. TB PCR we are not sending, we are sending gene expert. So gene expert, even if it is done properly, will be negative in most of the cases. Why? Because you're sampling the endometrium. The disease may be in the tubes. You are sampling the endometrium, but if the fibrosis sets in,
You will not get
all
any.
the bacteria are submucosal and most of the damage is immunological. It's not because of the bacteria dividing. It's a slow growing bacteria. So how many ever samples you take, the test will be negative. So many patients are denied ATT because they say test is negative. But a positive test does not mean disease and a negative test does not mean absence of the disease. So if you feel that there is a family history, there are very typical features, and that is why we have published our findings in British Journal so that any practitioner can be protected. We have clearly shown that most of the cases our endometrial biopsies were negative, and we have given, now this is called as the CRS. CRS is Composite Reference Standard. This term is coined by Dr. J.B. Sharma, who has, I think, maximum publications in the world on tuberculosis. So CRS means clinical history, family history, the geographical area from which the patient comes, the ultrasound, hysteroscopy, laparoscopy, and the test, everything together has to be considered. And nobody will penalize you for starting ATT if you are able to justify and you are able to quote.
So we need to send information to the local authority about all the findings, then get the confirmation and start the ATT.
Yes, so there is no need to inform the authorities. You can just start the ATT to your patient. ATT is now actually not available on sale most of the places.
Yeah.
So the patient, you have to go to Nikshay portal and notify your patient. They will make the arrangements for the drugs to be delivered to the patient. Most of the states, there will be an NGO who will do all the coordination. Sometimes test will also can be given from tuberculosis center if it's not a high endemic area. Patient will get 500 rupees per month for nutritional assessment, for nutritional assistance.
Okay.
The notifying doctor will get 500 rupees for every notification that you do.
Okay.
If you don't notify, it is an offense. So currently I'm working with the state STF of all the states to bring this knowledge to all the gynecologists, how to operate the Nikshay portal. If you say we can do a hands-on session on how to notify our patients, inform to the authorities, we can also involve our state authorities.
Okay. Okay. Sumita,
Because
you
the
got that?
low
Yes, ma'am.
prevalence.
That's great, ma'am. Thank you, ma'am. Thank you, ma'am. Ma'am, just one last question. Gene expert and RT-PCR, which is better?
It's the same. So Gene Expert is the name of the machine. and it is a type of PCR, but it's an automated PCR. So the machine will do everything for you. And it is free of cost. So if you send it to government, it will be done free of cost. Private labs, it will be done, but private labs, I'm not happy with their reports. I don't think they're processing it properly because we get only negative. All the tests are negative.
Thank you, ma'am. Thank you so
Yeah,
much for that.
in a case where you have already gone in for amenorrhea and laparoscopy shows a cocoon abdomen, do you think that our antituberculosis is going to support the patient in getting her menstruation back? How much is a chance in your experience? And how much is the chance of fertility?
Ma'am, I have had a lot of patients who actually come to us with primary amenorrhea. May sound shocking, but we still get patients with primary amenorrhea. So the patient that I showed last, she resumed her menses despite primary amenorrhea, but the endometrium is pathetic. Now I feel that if there is a complete amenorrhea, the chances of resumption of menses are not great. We tell the patient and do it. But I feel that this treatment has to be done because this
Yes.
bacteria can spread to other organs. She has
At
abdominal
any time, she can
tuberculosis.
develop a tuberculosis of the spine also, because
Yes.
extrapelvic
So-
tuberculosis is prone for all these things. So anti-tuberculosis treatment is a must. But the patient comes to us not with a history of tuberculosis, and she has come with only with the findings somebody done, has seen extensive, if they see adhesions between the intestines and peritoneum, ovary is not visualized, frozen pelvis, endometrium, thin hysteroscopy could not be passed. So put the diagnosis Asherman syndrome with pelvic infection. But it is really a tuberculosis which should have been occurred earlier in our life. That is
Actually, true.
yeah. So
I-
in that case, probably the present ART methods have to be suggested for her along with anti-tuberculosis treatment, telling her that this is for her long-term management. Am I right, Priya?
Very true. And we have made this mistake earlier. Whenever we would see Asherman syndrome, we would be very happy and start doing the adhesiolysis. 2 or 3 of my patients landed up with a condition of myometrial tuberculosis.
Yes,
Because-
we'll be pushing it inside.
Yes, so the problem is they developed big cystic areas in the myometrium and the endometrium never developed. So now whenever I see active tuberculosis, I will give her ATT for 6 to 9 months and then I will do the adhesiolysis.
Do you suggest PRP in these cases?
So our
Stem
initial
cell
5
transfer,
or
the
6
latest
PRP
one is
cases,
stem cell.
I have
Latest
actually
is-
no experience with stem cells. We are not licensed and I am still more
No,
cautious
from your
type of
literature
person.
review
I'll
which
wait.
you would have done. I'm also not doing stem cells. Of course, we are doing PRP in layer cases, but stem cells, we are from literature review for the sake of audience, because they come with somebody has suggested stem cells because they Google out, That is why I'm discussing with this for the sake of 75 members who have joined with us today.
Yes, ma'am. I have also sent some of my patients to the people who were doing stem cell therapy thrice, I think, and none of the times I had a good success. I think this treatment is evolving. With time, we will know what works and
Yes.
how it works.
Okay, thank you.
Next question is from Dr. Saurav, and he's asking, like, what is the common test for chronic endometritis to rule it out?
So, 2, 3 things. First is a good ultrasound. Ultrasound will not show you micropolyps. It will not show you focal hyperemia, but it will show you fluid in the endometrium, non-specific appearance of endometrium, and sometimes even multiple polyps in the endometrium is a feature of chronic endometritis. Many times we see patients repeatedly having the polyps, and polyp is always positive for MUM1. All the polyp samples that we've sent for MUM1 have come out to be positive.
Okay.
So some polyps are not hormonal. Probably they are also because of endometritis, but we don't have any data to say it, but that has been our experience. So first is an ultrasound. Second is a hysteroscopy, which is done properly with a vaginoscopic technique. Please note the stromal edema if it is present in the proliferative phase, micropolyps and focal hyperemia. And please send for MUM1. I feel MUM1 is the gold standard test because presence of even single plasma cells in one HPF is a pathognomonic of chronic endometritis. So I think MUM1 will show you inflammation. If you want to know the bacteria which causes inflammation, some PCR or NGS based test, one of them is DISPAN.
And Dr. Priyadarshini Moganasundram has said it's an excellent lecture, ma'am. And she's asked, like, will you treat those micropolyps during the time of hysteroscopy?
No, we can't treat the micropolyps is less than 1 millimeter. So there's no point trying to cut them. In fact, most of the time with the pressure of the fluid, they'll start,
Yes, sir.
floating here and there.
Okay.
But we just have to note that they are present. And I've tried several times to take sample from that site where I found the micropolyps so that I'm able to see in histopathology, but I have not succeeded.
In
In
taking out
so
the
many
polyp.
cases we have tried, we've never
Yeah.
succeeded.
Okay. Dr. Indumati is asking, endometrial fluid aspiration and treatment based on culture sensitivity. Will it be useful?
We've done it so many times and we found nothing.
Nothing there. Okay. Dr. Arulmoli is asking, like, can you repeat the 5 tests to be done on an endometrial sample, please?
So biopsy, Gene Expert Plus. So Gene Expert Plus does a smear, culture, and Gene Expert, all three. Then we do MUM1.
Nice.
So these are the and DICE if MUM1 is positive.
Okay.
And there is no history of tuberculosis.
And
So
Dr.
smear culture and Gene Expert for tuberculosis and MUM1 and his biopsy.
Okay. And Dr. Indumati is asking, like, what is a confirmatory test for tuberculosis in a endometrial sample?
None. There's
And
no
there's
test.
no confirmatory test at all. Okay. And Dr. Megha said it's a wonderful talk, even though she has joined late. Thank you, Megha, for joining. Happy Navaratri. And Dr. Chitra is saying we do CB-NAT with an endometrial tissue. If it is negative, what do we do?
CB-NAT is the same as Gene Expert. So Gene Expert, PCR, everything is the same. Currently, the platform that everyone is using is Gene Expert, which is the synonym of CB-NAT. So
Okay.
if Gene Expert is negative, she's asking.
No. If CB-NAT, same.
CB-NAT
If
is-
negative, what will you do? If CB-NAT, if Gene Expect is negative, what will you do?
Nothing. If Gene Expert is negative, it doesn't mean that she doesn't have tuberculosis.
Tuberculosis.
So we will still look for, if we clinically suspect, we will still look for laparoscopy findings. We'll still look for features of endometritis. So it's not that if Gene Expert is negative, you can't have genital tuberculosis because this is EPTB. And see, remember, endometrium is going to be shed off every month. So even if there are few bacteria, it's posibacillary. So you may not find, there may be a sampling error. You're dividing the sample into 4 parts. So that part may not have the bacteria which you have sent for Gene Expert. So we have to understand the limitation of the test and the nature of the disease. So negative Gene Expert does not mean much.
Okay. Dr. Aarti is asking, like, will you proceed with the removal of the caseating mass or you'll just start ATT?
Yes, very good question. And again, we have made this mistake. Earlier, we would not remove these big caseous balls, thinking that it is just necrosis. And we found that it takes so much longer and clinically the
Right.
patient doesn't get cured. So we went back to our very old textbooks and we found that actually surgical treatment of genital tuberculosis is described in Thielen 20-30 years ago. So whenever there are big caseous masses, always remove the tube because this will keep on inoculating more bacteria and she'll never get treated. So all the caseous masses have to be removed. If the tube is unhealthy, I don't do clipping. I'll do a salpingectomy for this patient.
That's correct.
Yeah. Thank you. Dr. Lekha is asking, like, persistent post-menopausal endometrial fluid collection not subsiding with antibiotics. What is your opinion, madam? And the ET is 2 millimeters with no vascularity action.
This happens in some menopausal women. I think it's probably because of cervical
stenosis.
Yeah. So maybe you just dilate it and check. And also, I think you can send for a DICE panel because there could be some changes in the microbiome also.
Okay. And Dr. Priyadarshini is asking if subendometrial calcification is the only finding on ultrasound. How will you proceed?
Most of these patients I have seen have tuberculosis. Maybe Jaya, Madam Charmila, all the seniors can add if they have
Can
seen
endometriosis cause a calcification there? Endometriosis. Adenomyosis.
Yeah, it is theoretical. They are saying that endometrial calcification. As you have already said, every month endometrium is getting shed.
No, subendometrial, below the
It's
endometrial
a
layer.
little rare finding. Once calcification has occurred, that means the stroma is already damaged. In that case, probably take it that this is, as we have said, extra this pulmonary tuberculosis is to be treated. We have to treat it on the conditions only.
And if unmarried 18 years female with secondary amenorrhea, how will you investigate? This is
All of us know the
Mm.
evaluation of primary
Mm.
amenorrhea, but you will be shocked that in 1 year, I have seen last 1 year, 3 girls with primary amenorrhea due to tuberculosis.
Okay.
So no bleeding with estrogen and progesterone challenge. So what we do is, we all know that, we have to check FSH, LH and estradiol.
Mm.
If it is low or normal, it is likely to be hypo. If it is high, it is likely to be primary ovarian failure. Of
Yeah.
course, other than the cases of MRKH.
Yeah.
So whenever a patient has normal FSH, LH, estradiol, or the patient has high estradiol and normal FSH, LH on a random day, I always think of tuberculosis.
Very good.
Yes.
Correct.
And
Perfect.
we give estrogen if her endometrium doesn't develop. I have taken consent and done a transvaginal scan. I've done a laparoscopy. I wish I had added this in this presentation. But I have now a series of 7 cases of primary amenorrhea due to tuberculosis, and none of them got their menses back even after 18.
18.
Correct.
Okay. Dr. Jayashree Natarajan is saying like it's an excellent talk. And is there a role of injection Plecentrix for patients with chronic endometritis?
I have never given. I use when I was training, it used to be given. So I think currently it is not even available.
No, it's there still.
Some places it's available,
It's available.
but it is not yet evidence-based.
Yes.
And will Dr. Shanta Shekhar is asking, I think you already answered, but
Answer.
will
Yeah.
a hysteroscopic biopsy from a micropolyp area increase the diagnosis?
No, we've tried a lot of times. Nothing
It
is
is not
I have
possible.
sat with histopathologists trying to scan, but I have never seen. I saw it only once in Dr. Ciccinelli's article on 2011 in Human Reproduction Update. He has beautifully shown biopsy of the polyp. That also I forgot to put here, but I have never seen in my patients.
Okay. My question is, the cost of the test of MUM1 you said is 2,000, right?
Now in our hospital, it is 3,500 currently.
500. Okay. What is the cost of the DICE panel?
DICE panel is, I think, 4,000 or something.
4,000. Because we had that ELISE test by the other group, no, the Spanish group. They were doing.
Yes.
So
Very
they were
costly.
charging 25,000. They were charging, I think, for
That is, they are doing the NGS based next generation sequencing.
okay.
So
Like,
they are also telling about the microbiome
okay.
proportion of this thing.
Oh. Like if the patient can afford, what will be the better test, DICE panel or ELISE test?
Actually, I have not done Alice much. They had shown me we do a lot of ERA, but Alice I've never done
Okay.
because I don't think my patients can afford. But I think just say next generation sequencing will become cheaper. I think that will be more accurate than PCR based methods.
Okay. So DICE panel is based on what? NGS.
PCR. It's PCR.
So if a patient can afford, ELISE will be better than NGS will be much better, no?
Absolutely no idea about it because NGS will actually, pick up a lot of noise. So that signal to noise ratio is also important.
Okay.
We really don't know the normal proportion of bacteria in the uterus yet.
Okay. Okay.
So we may actually end up, so this is just
Over-treating it.
allowed. Yeah, I really don't know. I have no experience. I've never sent.
So from a country like India, this question is always rises. Why not I give antibiotics if I suspect an endometritis instead of spending 6,000 rupees on 2 tests? Is it feasible?
That is because, see, all of us struggle with endometrium. We find after giving doxy, azithro, still the fluid will be present.
Okay.
Sometimes we have repeated MUM1 and repeated MUM1 is also positive. So then, we were actually forced to start testing. You can imagine 10,000 patients standing only on the endometrial tests in our unit. It is too much.
Okay. Okay.
But we were forced to start sending DICE because nowadays there is an epidemic of these endometrial fluids because we are doing only frozen transfers.
Okay. Okay. And there somebody, I think Dr. Pooja is saying there's something called an EMMA panel, just equivalent test called Empower panel. What is it?
So EMMA, ELIS, and ERA, all 3 are by iGenomics.
Okay.
I have never sent EMMA, I have never sent Alice, so I have absolutely no idea about it.
Charmila, there is another panel called Prema.
How much is that?
It includes progesterone also. That's called Prema.
How much is that cost?
Which one? Prema. I have no idea. I'm not doing it because I see cases like this referred to me because somebody says, I have been treated by Jayam Kannan 30 years ago, 40 years ago, so go to her.
Okay. Okay. And I had a
referred to me who has been delivered 47 years ago by me. Sitting
Okay,
in
okay.
Germany, he said, my mother has delivered 20 years after marriage by Dr. Jayam Kannan. So we'll see if she is there, you go to her.
Okay, okay. Because I had a professor, Sir Dr. Bomsi Wadia in Bombay. Sir was like any infertility, he will put a lap and he will see some tubercle somewhere and he'll start everybody on AKT and he'll start them on Cifran also, ciprofloxacin also. And we all used to like think there's no logic to it, but I think we are going back to the same almost now. Because you don't have a test to still confirm tuberculosis, extrapulmonary tuberculosis in the endometrium. You don't have anything to prove your genital tuberculosis. And I think we are going back to we used to make like at the back of him, of course, we used to make fun of him, like there's no logic and all that, but somehow it seems to be going back. Dr. Sumita Lakshmi wants to ask another question. Please unmute yourself and ask.
Ma'am, just to add one more, we have an endometritis panel in most of the labs at Chennai, ma'am, and
Okay.
suburbs, wherein,
Okay.
you know, ma'am, it is costing around 2,000 to 2,200, where we do
Okay.
a screening for chlamydia, gonorrhea, mycoplasma genitalium, herpes, ureaplasma, TB, and mycobacterium tuberculosis.
What
As
is
you just said,
specimen?
a simple
From
doxy and
now from which specimen?
map from endometrium. It's a
Endometrium.
PCR.
Okay.
It's a PCR and it's just 2,200 roughly. So you can just verify through the labs, ma'am. So it
Okay.
has come out latestly. So I think, as madam said, the DICE panel would be more similar to this, which is
Okay.
practically and economically possible in most of the times. And the
So
treatment is going to be obviously different for each cases,
no, I
ma'am.
would
The doxy
suggest
and
you do a data collection of all your cases and
I'll do
provide it
that,
to
ma'am. I'm
Priya
doing it,
and
ma'am.
compare it
I'm
with the
doing it.
DICE panel. So we'll get an idea
Sure.
which is better. The
Yes,
cost
madam.
should
Sure.
not matter if you get a
It's
good report.
economical. Yeah. That's the only thing, ma'am, because most of our patients couldn't afford. So I
Okay.
just wanted to add on to it, ma'am.
You
And
are
PRP, as Jayam madam said, I just attended the Regenerative National Conference last month. They
okay.
said 1 month prior to ET. One
Okay.
month prior to ET is the ideal time when we do a PRP. On the same cycle, if you're doing an PRP, it's not going to work, ma'am. So that is what was that.
We
Another
want your
addition.
data. We want your data on that.
We will do it, ma'am. We
Yeah.
will definitely
And
send you.
you are a part of AART, our society.
Yes, ma'am. Yes, ma'am.
Yeah,
I'm from
So,
IFS, ma'am. I was delivered by Jayam Kannan, ma'am.
madam, I think all your babies are here. All your babies are here.
Thank you, Sumita. Sumita, did you hear anything from about stem cells?
Yes, ma'am. Mesenchymal stem cells, they are starting, ma'am. But PRP is actually they've been using it right now. And stem cells, they have not much of use in gynec, ma'am. But in other fields, they are using it a lot.
Yeah,
But
that I
endometrial.
know. Even my son Arun, hip and knee orthopedics is using a lot.
Yes, ma'am.
But,
Orthopedics left and right.
Yeah, in endometrial proliferation, Asherman syndrome, giving a stem cells is a question. Where to put the stem cells is a question. Because
Yes,
there
ma'am.
is
Yes,
no
ma'am.
area where we can specify it. You know?
It's not
Yes,
worked
ma'am.
in any of my patients whom I've sent
That's why
in
I asked you,
treatment.
because you attended the conference.
When nothing
To
works,
see my
ma'am,
baby, no,
we
yes.
just started. Sorry.
I said 47
Yes.
years ago, I have delivered my first infertility patient. Now Sumita should be the next decade group.
Yes, ma'am. Thank you. Thank you so much, ma'am. Thanks for the opportunity.
Yeah.
A beautiful talk, wonderful interaction. So
Lovely.
as there are no more questions, I would like to wrap it up. And a special thanks to Priya, who has spent such your valuable time with us. We'll call you back and we'll need your inputs again on the new work which you'll be doing, definitely, I know. So we'll call you back. Thank you so much for joining us today. Manjula, can you give the vote of thanks, please? I would like to thank all the delegates who have joined today. It's an honor that all of you have joined today. And I've always admired Priya for the way she has always put her thoughts and so much of clarity.
Sharmila, one more suggestion.
Yes,
Since Priya Bhave has gone with JP Sharma, and probably the next lecture, if he
JB, I'll call sir. I'll call JB.
We have put it to him that you have talked about these things. Let him improve on this. Only talk about urogenital tuberculosis.
Yeah. I'll ask him to talk.
So that next lecture will give better information to our ART members.
Okay,
for whom we have started this to learn on this.
I'll talk to sir.
Thank you, Priya. Thank you, Charmila.
Thank you, madam. Thank you. Manjula, formal vote of thanks. I'll give it. Okay. She's traveling. Thank you. I would like to thank the speaker, Dr. Priya Bhave, all the delegates and who have attended as well as interacted. Great inputs from all of you. I'd like to thank the office bearers of ART, Dr. Jayam Kannan, Dr. Manjula. I think Dr. Shanti Priya has also joined. A special thanks to Shield Pharma for always supporting. Thanks to Dr. Ms. Sakhiti. Thank you, Sakhiti, for all your coordination. And I think no more questions. Thank you, Priya. Thank you so much for joining with us
Thank you
today.
so much, Charmila, and thank you, everybody. I think this is one of the most wonderful webinars I have attended, and I really enjoyed preparing for it. I'm sorry for the small hitches.
No problem.
And all of us should remember we have to end TB by 2025. That is the goal. So I think in the next webinar, please call me. I would like to attend as an audience.
Yes. Thank you, Priya. Thank you so much.
Thank you.
Become a
Thank you,
member
Dr.
of a
Priya.
society.
Thank you.
All over from
Yes,
India,
for
we
sure.
will send you the application. Thank you.
Yes.
Thank you, Dr. Priya.
Thank you.
Thank you.
Thank you. Thank you, Dr. Manjula. Good night.